Good afternoon. We're talking about common drugs in critical care. Central nervous system medications. This includes our analgesic. Medical name for painkillers to relieve pain, and we have the three groups. We have the opioids, non-opioids, and combined analgesics. It is also known as analgesics or opiates, and this is to ease moderate to severe pain are often prescribed to patients recovering from operations. And some of these examples are codeine, fentanyl, meperidine, methadone, morphine, pentazocine, and tramadol. We have to, as nursing implication, have to monitor the CNS changes, respiratory rate, and cardiovascular, which includes your ECG, heart rate, and blood pressure, and as well as evaluate the pain level using a quantitative scale. Monitor for diminished bowel sounds and constipation, which may be severe. And we have the dose and administration. Fentanyl, 50 to 100 microgram as bolus PRN, and 50 to 300 microgram per hour as infusion. And as well as we have the concentration for IV infusion. We have 2,500 microgram and 50 ml or 50 microgram per ml via syringe pump. Remifentanil IV infusion, 0.02 to 0.2 microgram per kg per minute. We have as well morphine, 10 milligrams as bolus PRN, IV infusion 1 to 10 milligrams per hour, 50 milligrams in 50 ml in 0.9 normal saline or dextrose 5% term 1 milligram per vial via syringe. We have tramadol, 50 to 100 milligrams bolus PRN, and codeine 100 milligrams PRN. We have as well as combined analgesics. Both we have mild non-opioid drugs such as aspirin or paracetamol with a small amount of opioid in single tablet. These combinations analgesics are often prescribed to people who are not benefiting from non-opioids such as paracetamol alone. People who experience migraines may use combinations analgesics. This includes your aspirin with codeine. This is an opioid. Paracetamol with codeine is an opioid. Dextromethorphan opioid with paracetamol, and dihydrocodeine opioid with paracetamol and your Tylenol. Indications for sedations. We have for fear or anxiety, difficulty of sleeping, control of agitation, facilitation of mechanical ventilation and airway management, as well as protection against myocardial ischemia, amnesia during neurovascular blockade. One of the examples is that Propofol or Diprivan, short-acting general anesthetic agent, maintenance of ICU sedation. We have 0.3 microgram per kg per hour, increased by increments of 0.35 milligram to 5 milligram kilogram per hour every 5 minutes until desired level of sedation. The maximum dose will be 5 milligrams per kg per hour or 0.5 cc per kg per hour. Higher doses have been associated with heart failure when administered to neuro patient. May administer boluses of 10 to 20 milligrams to rapidly increase sedation in patients not prone to hypotension. Administration could be infusion, undiluted, must change IV tubings and bottles Q12 hours when running as continuous infusion. Should we wind off to prevent rapid reversal of sedation? We have the adverse effects. We have to monitor hypotension, bradycardia, arrhythmias, apnea, airway obstruction, seizures, cough, and as well hyperlipidemia, excitatory phenomena, headache, dizziness, agitation, anxiety, confusion, hallucination, and nausea and vomiting plus abdominal cramping, and may discolor urine to green color. We have midazolam. This is an anxiolytic agent, sedative, anti-convulsant. The dose will be 3 to 5 milligrams. Infusion initiate at 1 to 5 milligrams per hour. Titrate to individual response or tolerance may occur. Administration 15 milligrams and 3 ml ampule. Diluted 45 milligrams in 36 ml of normal saline or D5% concentration 1 milligram per ml using a syringe pump. Adverse effects, of course, we have to monitor the respiratory depression, hypertension or hypotension, headache, drowsiness, dizziness, thrombophlebitis, amnesia as well. We have to monitor the vital signs that includes as well your heart rate, very important, ECG, arterial blood pressure, respiratory rate, and response to sedation. We have the ketamine. It is an analgesic and anesthetic agent. It produces an anesthetic characterized by profound analgesia but without any sedation, hypnosis, or effect on pharyngeal and laryngeal reflexes. For induction of anesthesia, the dose would be 1 to 2 milligram per kilogram IV bolus over 1 to 2 minutes, or 4 to 8 milligrams per kg IM, or 50% of induction dose repeated as necessary for maintenance of anesthesia. And as well as for treatment of bronchospasm, the dose would be 1 to 2 milligrams per kilogram induction followed by 0.1 to 0.5 milligrams per minute maintenance infusion. For sedation and analgesia during procedure, the dose would be 0.2 to 1 milligram per kilogram over 2 to 3 minutes, followed by continuous infusion of 5 to 20 microgram per kg per minute, or repeated as required. Administration, if continuous IV infusion, it would be 500 milligrams and 500 ml of D5 water or normal saline. Intermittent IV infusion, dilute in D5 water to maximum concentration of 5 milligrams per ml. We have to monitor BP, heart rate, respiratory rate, oxygen saturation, as well as blood gases, skeletal muscle tone and presence of emergence reaction, level of consciousness, and adequacy of pain control. We have haloperidol. It is an antipsychotic, anxiolytic. Intermittent bolus dose would be 2.5 to 5 milligrams as IV infusion every 30 minutes at 2 Q6 hours. It could be given as IV infusion. We have to observe for adverse effects, which is tachycardia, hypotension, and hypertension. For the CNS, we had to monitor as well as agitation, restlessness, seizure, dry mouth, constipation, anemia, leukopenia, and as well as we had to monitor the ECG changes. We had to monitor the mental status as well as your blood laboratories, which include your CBC, liver enzymes, muscular tone, joints, and as well as rashes for the skin. Lorazepam, or we have the Ativan as a sedative or amnesic drug. It is used to treat seizures, relief of anxiety, and ICU sedation, as well as to induce chemotherapy, nausea, and vomiting. We have anti-convulsants, phenobarbital sodium. It is given to status epilepticus. We have the loading dose. We have the 15 milligrams per kg IV, and we have the maintenance dose 15 milligrams per kg as daily single dose, or 1.5 milligrams per kg Q8 hours. And we can give it undiluted or diluted. For diluted, we can give IV infusion 50 to 100 milligrams to be diluted in D5 water, normal saline, or lactated Rangers infusion. Okay. Next, the adverse effect that we had to monitor is respiratory depression, hypotension, and we had vital signs monitoring, which includes your respiratory rate, BP, heart rate, and ECG, arterial blood pressure, as well as serum concentration. The therapeutic pre-dose level is 65 to 170, and the toxic level is more than 215. And we have to monitor the administration site because it causes extravasation. We have the PHENYTOIN as anti-convulsants, anti-arrhythmic. Okay, the loading dose would be 14 to 18 milligrams per kg IV direct, and maintenance dose would be 5 milligrams per kg per day. And we are giving it as IV infusion mixed with normal saline and lactated Rangers. Do not mix with dextrose solution as precipitation will occur. We had to monitor as well the vital signs as well as seizure activity or neurological signs, and as well as phenytoin levels we had to monitor. And additional to that, hyperglycemia, nausea, nystagmus, and rashes. We have muscle relaxants. We have rocuronium as esmeron, vecoronium nocoron, cisatracurium nembex, succinylcholine anectine. This is used to facilitate mechanical ventilation, reduces airway resistance or pressure, reduces metabolic rate and oxygen consumption, used in management of tetanus, safe for use in patients with malignant hyperthermia, and may be used to stop muscle activity during a seizure but has no anticonvulsant properties. So the dose would be for rocuronium, the bolus would be 0.6 milligrams per kg direct, and IV infusion would be 0.06 to 7.2 milligrams per kg per hour. 50 milligrams, 50 ml D5 water, normal saline or lactated Rangers for syringe pump infusion. For vecoronium, we have bolus 0.05 to 0.1 milligrams per kg IV direct. Onset of action 4 minutes, duration of action 20 to 30 minutes, continuous infusion. Cisatracurium, the bolus dose would be 2 to 10 milligrams IV and infusion would be 2 to 10 milligrams per hour, undiluted 15 milligrams in 50 cc syringe via syringe pump. We had to note for CNS effects, therefore may be fully conscious and able to comprehend, hear, and remember conversation. Has no analgesic or sedative properties. Patients require continuous analgesics and sedative administration. Pupils and GI tract are not affected. So we have to assess motor reflexes regularly, and as well as your vital signs, because it may cause bradycardia, tachycardia, increase in blood pressure, as well as we had to monitor for it may cause hyperkalemia. Cardiovascular system drugs, this includes your ACE inhibitors, helps your blood vessels relax and open up and used to lower blood pressure and to make it easier for the heart to work. It improves performance of the heart, dilatation of arteries and veins. What are those examples? We have your enalapril, lisinopril, kenapril, lisinopril, and captopril. So this it indicated for hypertension, treatment and prevention of heart failure, treatment and prevention of diabetic neuropathy. So we have to monitor for angioedema, swelling of the throat and airway that rarely occurs commonly after the first few doses. We have to monitor for persistent chronic cough, which typically develops about 1 month after starting therapy. Monitor electrolytes for hyperkalemia, and it's contraindicated in pregnancy after 20 weeks. May cause renal impairment, so we had to monitor serum creatinine and BUN. We have the beta blockers as well, which reduce blood pressure and improve heart performance by reducing heart rate, thereby decreasing the work of the heart. So we have the labetalol. The bolus dose would be 5 to 20 milligrams IV direct over a 2-minute period bolus and should be diluted to a concentration of 1 milligram per ml at 10-minute interval. IV infusion 100 milligrams and 100 ml in D5 water, normal saline or lactated Rangers. We have the another examples. We have your metoprolol, atenolol, and propanolol. The bolus dose would be 1 to 3 milligrams IV direct at 0.5 milligrams per minute, the maximum of 0.15 milligrams per kg. And as well as could be given IV infusion with the dose of 0.1 to 5 milligrams per hour and titrate the effect. The dose would be 10 milligrams and 100 ml, D5 water, normal saline, and lactated Rangers, and should be weaned off. We have anti-arrhythmics drugs. And these drugs help to stop the heart from producing abnormal or dangerously irregular beats. So we have amiodarone or cordarone. This is decrease dangerous heart rhythm disturbances, useful for treating irregular heartbeats from the lower part of the heart. So the dose would be 150 to 300 milligrams IV, maximum infusion rate at 30 milligrams per minute, and for continuous infusion at 900 to 1,200 milligrams over 24 hours. And we have to monitor ECG rhythm, QT interval, cardiac index, breath sound, chest x-ray, and as well as liver enzymes. We have the lidocaine, decreases ventricular excitability and slightly decreases the force of the ventricular contraction. If injected locally, it produces local anesthesia. So The indication would be given to hemodynamically unstable premature ventricular contractions, ventricular tachycardia, ventricular fibrillation, and useful as a local anesthesia during minor surgeries. We have to monitor ECG and blood pressure, what's for change in the level of consciousness, confusion, and excitability. What are those drugs that slow the heart? And that includes our adenosine or adenocard. Slow electrical conduction in the AV node. Indication is paroxysmal supraventricular tachycardia. The bolus dose would be 6 milligrams IB rapid bolus. Repeat with 12 milligrams IB bolus every 1 to 2 minutes. A maximum total dose of 30 milligrams should be given as close to the site and as quickly as possible. We have to monitor the ECG, the rhythm, blood pressure, cause bronchial constriction and chest tightness, which lasts seconds to minutes. We have the diltiazem as well. We have the digoxin, which is the Lanoxin, which is cardiac glycoside. Treatment of atrial fibrillation, atrial flutter, and atrial tachycardia. So the dose would be for congestive heart failure, the loading dose would be 8 to 10 microgram per kg for the lean body weight, and half of the total dose given as first dose, and additional fractions are given at 6 to 8 hour intervals. Maintenance dose is one-third of the loading dose per day. For atrial fibrillation, loading dose will be 10 to 15 microgram per kg lean body weight with administered as above. Reduced dosage in renal failure, hypothyroidism. Digoxin toxicity. What are the symptoms of digoxin toxicity? We have gastrointestinal effects, which include sure anorexia, nausea, and vomiting is the common early signs of toxicity. For the CNS effects, headache, fatigue, drowsiness, general muscle weakness, ocular effects could be yellow and green halo vision. Effects on potassium, it will be chronic toxicity, it could be hypokalemia. Acute toxicity will be hyperkalemia. In cardiac effects, every kind of arrhythmia, AV block, atrial fibrillation with complete heart block, very suggestive of digoxin toxicity. Drugs that speed up the heart, that includes your epinephrine, increased myocardial contractility, used to treat bradycardia, severe left ventricular dysfunction, or anaphylaxis. Vasoconstriction, used in profound hypotension or pulseless cardiac arrest to promote systemic perfusion pressure gradient. The dose would be 1 milligram IV direct. Single IV doses of up to 10 milligrams had been used on ventricular fibrillation. Infusion would be 0.01 to 0.2 microgram per kg per minute, and the dilution would be 10 milligrams in 100 ml of the 5% using your Abbott pump. We have the atropine sulfate. This is the treatment for symptomatic sinus bradycardia and the antidote for sinus bradycardia induced by drugs or toxic substances, and reduces as well salivation and excessive secretion as the respiratory tract. So IV direct would be, the dose would be 0.5 to 1 milligram every 3 to 5 minutes until desired rate achieved. And IM and sub-Q would be 0.4 to 0.6 milligrams Q4 to 6 hour PRN. When used as cholinergic antidote, may require larger frequent doses. Okay, may be given via endotracheal tube if IV administration not possible. We have as well sodium bicarbonate. So the indication will be for aspirin overdose or class 1 if known pre-existing hyperkalemia. The dose would be 1 milliequivalent per kg IV bolus, and repeat half this dose every 10 minutes thereafter. We have the bronchodilators. We have aminophylline, epratropium, salbutamol, and it is indicated for asthma in some patients and prevention of neonatal apnea. Our nursing responsibility includes monitor serum drug levels and ECG and assess for signs of drug toxicity, which include sure tachycardia, tremor, nausea, and vomiting. And these drugs may cause refractory seizures. Aminophylline must be given by slow infusion. We have the inotropes, drugs that increase the strength of the heart. We have dobutamine or Dobutrex. Vasodilator, help blood vessels relax and open, and used to lower blood pressure and to improve blood flow to the heart, muscle, and other organs. As well, the dose for infusion with 2.5 to 10 microgram per kg per minute. And we have to monitor heart rate, ECG, BP, as well as cardiac index, and as well as a catheter could be inserted. And we have to monitor as well electrolytes, arterial lactate, urine output, and blood glucose. And as well as for IV infusion, our concentration would be 1,000 milligrams and 250 ml D5 water or normal saline. Dopamine, vasopressor drugs make blood vessels smaller and tighter. Okay, the dose would be renal dose is 3 microgram per kg per minute, and cardiac dose would be 5 to 20 microgram per kg per minute, and the administration would be IV infusion. The dilution is 800 milligrams and 250 ml of Dex 5% or normal saline. Monitor ECG for widened QRS complex, arrhythmias, heart rate, and blood pressure continuously. Monitor hemodynamic parameters if available, and avoid soft tissue extravasation which may cause skin necrosis. We have norepinephrine, your Noradrenaline, and your Levophed. This is a sympathomimetic vasopressor. Stimulates alpha-adrenergic receptors, producing vasoconstriction and decrease the heart rate. At low doses, stimulates beta-adrenergic receptors to enhance myocardial contractility. The dose would be 0.05 to 0.2 microgram per kg per minute and could be given IV infusion by a central venous catheter. The dilution is that 32 milligrams into 50 ml Dex 5% or normal saline. Color change from clear to brown indicates a loss of potency and should be weaned off. We had to don't administer to a patient with peripheral vascular thrombosis. Monitor capillary refill because high dose may cause necrosis of extremities. Avoid extravasation, which may cause tissue necrosis and infuse through central line. Monitor the patient's cardiovascular status, central venous pressure, pulmonary artery pressure, intake, and output. This drug may cause hypertension, arrhythmias, ventricular tachycardia, and ventricular fibrillation. We have the phenylephrine, sympathomimetic vasopressor as well. Stimulates the alpha-adrenergic receptors, resulting in vasoconstriction, decreased heart rate, increased peripheral resistance, and used to increase blood pressure. Our bolus dose would be if hypotension or shock would be 0.1 to 0.5 milligrams as slow IV direct injection every 10 to 15 minutes or 1 to 10 milligrams IM sub-QQ 1 to 2 hours. For paroxysmal supraventricular tachycardia, the dose would be 0.5 to 1 milligram as rapid direct IV injection every 60 to 90 seconds. For IV infusion, we had the dose of 0.04 to 0.18 milligrams per minute titrated to effect. The concentration with 100 milligrams in 100 ml or 100 milligrams in 250 ml D5 water or normal saline. VASOPRESSIN, it's anti-diuretic hormone. It stimulates vascular vasopressin and as well as stimulate your V2 receptors and renal tubules to cause fluid retention and prevent fluid loss. So the dose would be 40 units and 2 ml and 100 ml of D5 water or normal saline. Pulseless cardiac arrest, 40 units IV, and it's no benefit if there is ventricular tachycardia and ventricular fibrillation, but may be useful in PAA arrest. Septic shock, 0.02 to 0.04 units per minute, and do not titrate, run at fixed dose. Administration would be IV infusion, 40 units and 100 ml D5 water. Have to monitor the BP, heart rate, ECG, urine output, as well as changes in the skin color, temperature, chest pain, diarrhea, and abdominal pain. So we have nitroglycerin vasodilator. It relaxes arterial venous smooth muscle to decrease preload with mild afterload reduction. So the dose would be 5 microgram per minute as initial dose, and administration IV infusion with 50 milligrams in 250 ml D5 water or normal saline. The maximum concentration would be 200 milligrams and 250 ml. We have the magnesium sulfate. This is for CNS and respiratory depressant effects and prevents or controls seizures by blocking neuromuscular transmission. the nursing implication that we had to monitor is that infuse IV bolus dose slowly to avoid respiratory or cardiac arrest, and monitor ECG and serum magnesium level. The dose, please, we have our GICU electrolyte protocol. For potassium chloride, the indication is for treatment and prevention of hypokalemia, and as well as we have GICU electrolyte protocol for the doses. The implication that we had to monitor, of course, we have to observe and follow the hospital policy that limits the rate of administration and concentration of IV solution. And for oral solutions are rapidly absorbed but have a poor taste, and we have to not to cross sustained release or oral doses. And drugs used in coagulation disorders are, we have the heparin, and it's indicated to prevent deep vein thrombosis, anticoagulant during cardiac procedures, and acute pulmonary embolism. The dose will be 5,000 units IV infusion according to our APTT levels, and dilution would be 25,000 units and 100 mils of normal saline. And we had to watch for hematuria and other signs of bleeding, monitor the partial thromboplastin time for therapeutic effect of drug, check coagulation every 6 hours and 4 hours after adjustment on the dose, and as well as monitor platelets because drug may cause thrombocytopenia. And we have the low molecular weight heparins. We have your enoxaparin and tenzaparin, as well as this prevent the DVT and DIC as well, and atrial fibrillation. Nursing implications as well as the same with your heparin. Watch out for hematuria and other signs of bleeding. Warfarin is anticoagulant as well, and is indicated for treatment of chronic DVT, intravascular blood clot, prevention in patients with select clotting disorder, and stroke prevention and atrial fibrillation. We have to monitor the therapeutic protamine time and INR because this drug may cause bleeding, bruising, and allergic response. We have the drugs that assist with coagulation. We have your desmopressin or DDABP. This drug increases plasma levels of factor 13 in patients with hemophilia, and also has antidiuretic properties. And the dose would be for antidiuretic 2 microgram IBPRN, and for bleeding is 20 microgram IB infusion. Nursing implication, we had to monitor coagulation status, hypertension and hypotension, monitor signs of bleeding. Another one is we have phytonadione or vitamin K, stimulate hepatic synthesis of clotting factors that are depressed during warfarin therapy. And it indications for hypothrombinemia in patients taking warfarin and overdose involving warfarin-like rate poisons. Nursing implication, you had to monitor your international normalized ratio and hematocrit to ensure effects. Excessive dosage will make it difficult to restart warfarin in affected advanced liver disease. Infuse IV doses slowly to avoid hypertension. We have the antidotes. Flumazenil or Annexate, benzodiazepine antagonists, midazolam in volume. The dose would be 0.2 milligrams IV direct over 15 seconds in divided doses, maximum of 1 milligram. We have naloxone or Narcan, it's narcotic antagonists. For fentanyl, morphine, the dose would be 0.1 to 0.4 milligrams IV. We have calcium gluconate, antidote for verapamil, 1 to 2 grams IV. Atropine sulfate, antidote for verapamil, 1 milligrams IV. Glucagon, propanolol overdose. Acetylcysteine, antidote for acetaminophen and contrast media. Antizole or fomepizole, methanol, and ethylene glycol overdose. And thank you very much.